This brings up the question of immune support in cancer. But what if you have something that's protective of neutrophils a little bit, or NK cell activity in cancer? What about radiation and some of the other effects? We actually did a study at Bastyr where we looked at breast cancer radiation treatment and showed that it decreased NK cell activity. There really hasn't been that much study on immune effects of radiation and some chemo drugs. The chemo drugs, we know what's going on because typically you're measuring things, but radiation, not as much. Neutropenia, and also we don't know the time course and recovery for it typically. Neutropenia is the most common immune defect for chemotherapy in general, and it causes more of the delays or treatment failures than anything else. Oncologists typically monitor absolute neutrophil numbers. So you're looking at an absolute neutrophil number typically, and if it drops below what they want, then they'll typically try to stimulate it. Filgrastim is pretty commonly used. It's recombinant GCSF. It can increase neutrophil numbers, but it can also cause these typical side effects. If you have a patient on it, you can typically see they're going to have bone pain, fever, rash, and liver damage. Those are possible problems. I mentioned silymarin for this. All right, 5-year survival rates for this particular case, which was testicular cancer, are pretty good depending on the amount of spread. So it's 99% if it hasn't spread outside the testicle, 96% if it's spread to local lymph nodes, 75% for disseminated cancer. So you see it starts going down the more it's spread. And the more disseminated it is, the less the survival is. This is the same cancer that a certain bike rider had who took certain other drugs that were illegal. I won't mention his name, but it's Armstrong. And so standard treatment protocol is cisplatin, etoposide, and bleomycin. Cisplatin is an alkylating agent, causes neutropenia. It's very metagenic. Etoposide also causes neutropenia, but not an alkylating agent. And then bleomycin is separate here, also damages DNA, but its major adverse effect is lung damage. So a lot of times these protocols will have one or two agents that do the same thing. In this case, cisplatin and etoposide both cause neutropenia. So you basically need to bring the neutrophil number up, otherwise you can't use this pretty standard treatment. And you can see here that the survival rates are pretty good for the most part for testicular cancer. All right, another case study here to challenge us. 58-year-old female, supposed to be presents with an elevated white blood count, slightly enlarged spleen, blasts are about 1% of the CBC. Cytogenetic analysis determines the presence of Philadelphia chromosome, which is a translocation from 9 to 22. There are specific translocations, but I'm not going to go into that now. She was diagnosed with chronic CML, scheduled to begin therapy with imatinib, 400 milligrams per day. Imatinib's trade name is Gleevec, in about 2 weeks. She's currently taking St. John's wort for depression and anxiety symptoms, and you should advise her to discontinue the St. John's wort immediately, discontinue the St. John's wort, but start drinking grapefruit juice every day once the imatinib has started. Ramp down the St. John's wort over the next 2 weeks. Keep taking St. John's wort. She'll need it for the chemotherapy. Keep taking the St. John's wort. Just up the proposed dose of imatinib to 800 milligrams a day. Go ahead and vote. So, a couple points here. I have a correct answer, but it's only a correct answer depends a little bit. So, St. John's wort induces cytochrome P453A4, and that is the same enzyme that metabolizes imatinib. So that's the actual interaction here. So the problem is that if you induce that enzyme, and since she's been taking it already, the enzyme's already induced. So if you don't stop the St. John's wort immediately and let it and not take it for 2 weeks, it takes about 2 weeks for the induced enzyme levels to come back down to normal. So if you don't do that, then imatinib will be metabolized even faster, and that will be a problem. And imatinib is a fairly effective drug for CML, which we'll get to, especially Philadelphia chromosome CML. And I'll get to the... there is kind of another correct answer here, which is just keep taking the St. John's wort and up the proposed dose. The oncologist won't want to do this, however, because the rescue therapy for Imatinib is if it stops working at 400, you give it at 800. However, there's another complication too, which is the P glycoprotein, which is why you have to go up with it. So